So let me start that for us. Okay, so welcome everybody to Medicare for All. The time has come. We're very lucky to have Corinne Frugoni and Harvey with us. Today's session is going to be recorded, like I mentioned, and will be on the website soon. So I want to give a big thanks to the Friends of OLLI for helping make these kind of presentations possible. It's your gifts that help us bring quality programs. Also, I want to remind everybody, OLLI memberships are now open. They started up in July and they run through the whole year. And these memberships have a lot of benefits, like discounts on classes, access to the HSU library.
Oh, we lost your voice.
Can you hear me okay?
Now.
Yeah?
It went away, but now it's back.
Okay, all right, that's good. Like I was saying, these give you a lot of benefits like access to the HSU library, transportation, discounts for public transportation, and they just help you connect with the rest of the OLLI community. I also wanted to mention, I get the honor of hosting the Stay Connected, these Let's Connect with Tracy Barnes Priestley on Fridays, and their morning sessions where people get to.
We lost you again.
Can you hear me okay?
No, it was in and out.
Oh, that's.
You need to repeat it about Tracy Barnes Priestley.
Oh, Tracy Barnes Priestley. So if you don't know her yet, she is avid. She was a therapist for a few years in the community, and she gives out topics every week, and we get to have a discussion about it with a lot of fun people. So if you guys have a chance, you can register on our website. So this is just where an image where you can find the recordings. You can either click in this yellow arrow and go down to brown bag presentations, or you can go on our main page and just click the one in the middle. Closer look, the green arrow is where you can click and find the archives of the recording, including today's. I wanted to mention that questions for this presentation, we want to ask you to please wait till the end, or you can put them in the chat during the presentation and I'll be able to bring them up to Corinne or Patty at the end as well. We also ask that you mute yourselves so we can hear Patty and Corinne clearly. But other than that, I'll pass it off to Jane, and she's going to be introducing our speakers for us.
Again, welcome to you all, and we're very happy to have Corinne Frugoni and Patty Harvey with us today. Corinne is a retired family physician who has worked at United Indian Health Services and HSU Student Health Services, which I'm sure has given her quite a few experiences for years. And Patty Harvey is a retired teacher. They both have been single payer activists for decades, and I'm sure you've seen the multiple articles and discussions that have occurred. Both HCA and PNHP are organizations that educate and advocate for a unified public nonprofit health insurance system that will provide equal access to high quality health care for all residents in California and the nation. And I apologize for the telephone. I will mute myself, and welcome to you both. I'll turn it over to you.
Thank you. Thank you very much. Now I'm going to share my screen. And Medicare, the time has come. And here we are with our connection to HCA, Healthcare for All, and PNHP. And as was just noted, these organizations actually have been around in Humboldt for approximately 10 years, I believe, but they've been active in California for about 30 years and working for, as we advocate for, guaranteed, high quality, accessible. And when we say accessible, we mean financially accessible as well as every other way, equitable, transparent, single payer healthcare, regardless of race, ethnicity, income, job, or marital status, or national origin or documentation or anything else you can think of that differentiates one human being from another, because we feel that the need for healthcare is universal. And because of that, it is a universally needed system. And I have now, Callan, I need my tech helper. How do I get back? Oh,
Oh, I don't know. Oh dear. Oh no.
oh no.
I don't.
Okay, so I was just saying, we feel that there's a universal need for healthcare, because everyone at some time in their life needs medical attention. I don't think anyone goes through a whole lifetime without some kind of intervention, which is very necessary for optimum health. And here we have, I love this picture because it's very aspirational and it's sort of metaphorical for where we want to go, which is the mountaintop of single payer healthcare. And what we want to do today is describe to you what a single payer system would look like, what we need to change in order to have it, and how it would benefit all of us. So I'm going to back up a little bit and show you this picture of this very handsome young man who happens to be my son. And if you don't think he's the cutest thing you've ever seen, maybe you better check your Wi-Fi. But anyway, 27 years ago, this guy was a student in Sweden, at which time he began to have a really bad stomach ache, and it got worse and worse, and he just didn't want to do anything about it. And finally, because he was in such pain, he was persuaded to go to the hospital, where he was taken for immediate surgery for his appendix. And he wrote to me later and explained all this, and that was kind of a shocker. And he said, I know that you were probably worried about the cost. And this explains why he was so hesitant to go, because he was worried about the cost, because in our family at that time, we were what is called underinsured. We had private health insurance, we paid premiums, we had a huge deductible. And so we made a practice of avoiding every medical intervention we possibly could. And just, if what doesn't kill you makes you stronger. And that's what he was trying to do. And consequently, he actually put his life in danger. And that really scared me. So he said, don't worry, Mom, the bill was zero. I thought, oh my gosh, here's a country organized around the principle that healthcare is a human right. How fantastic. And the next question is, why don't we have it? And that sort of started my interest in pursuing the answer to that question. Why don't we have it? Instead, we have this fragmented, broken, inaccessible, expensive system that is, frankly, very much unsustainable. If we continue spending the way we do now on healthcare, we can expect in 10 years to be spending in California $350 billion more a year than we are now. We're already spending $400 billion a year in California. That almost doubles it in 10 years. We have got to have cost control. We've got to have accessibility. We've got to have high quality, and we have got to have transparency and guarantee it for everyone. So what does a single payer system look like? First of all, let's start with, what do we need and want? Here on the one side, you see the people, and on the left and on the right, what they want. They want to go to the doctor of their choice. They want to go to the hospital when they need to and pick the hospital that is best suited for them. They want their prescriptions filled in a timely fashion. And it just seems like, wow, is that so much to ask? Well, apparently it is, because here we have the same people and the same desires and needs, but what is all this that is in the middle? At the bottom, you see, I'm just going to talk about these things because it's very important what these middle operational agencies do to block and make inaccessible healthcare that we want and need. We have federal government and state government. We pay taxes to those governments, and those taxes support a lot of the programs that the governments espouse and have initiated, like Medicare and Medicaid, and many state programs for specific groups. Government also pays for the VA and the children's health and Indian health and lots of programs. We may or may not personally benefit from those programs, but our taxes will subsidize and help pay for them. If you are not participating in some kind of government program, you might get your health insurance from your employer, and that could be a government employer, as noted below, or it could be local government like county government or city government. And our taxes, fees, and input into local areas help subsidize those health insurance plans. We also have employers like private companies like Danco or like Humboldt State University, and all of their employees have health plans also. Those health plans require premiums, they have deductibles, and the employers are also paying into those plans. And so it's a shared effort to get coverage. Okay, again, any individual might not get their healthcare from their employer, but they may buy, as you see on the top, they may buy health insurance from a private company, a for-profit private company, and there are hundreds of them. And they also require premiums, and they have deductibles, which can be very high. And once you meet your deductible, then the insurance company is supposedly begins to pay your bills. However, they may not pay all of them. You may have many hidden costs. You may have surprise bills. You may have other obligations from out-of-network providers that you didn't even know were going to be attending to you. And so it is pretty chancy. Even with what you think, oh, I'm completely covered, I don't have to worry. But I think everyone by this time knows and has heard the horror stories of people who were thought they were completely covered, but somehow they end up going broke, bankrupt. The highest cause of bankruptcy in this country is medical bills. I imagine that a great percentage of the homeless people are there because they could not find the money to pay their rent or their house payments. And unfortunately, there are some 40,000 people in this country that lose their lives because they did not have appropriate access to health care. That's like a 9/11 every month. It is a travesty. It should not be happening. And now imagine that you're on the other side and you're a doctor or you're a hospital or a clinic, and you have to also deal with all of these guys in the middle. You may have, say you had a clinic with 200 patients. I'm just making this up. 200 patients, and all of them have different ways of having their bills paid. That means you have to hire extra people to sort through the requirements, the restrictions, pre-authorizations, coding, because they're all different. And so you need to hire extra people to take care of that. The doctor also, she spends 20% of her time on the phone arguing with insurance companies about what procedures will be paid for, or even what drugs that the doctor is allowed to prescribe according to the company's formularies. So it's very complex. A doctor could end up spending I've heard an average of $100,000 a year from her take from being a doctor just to deal with payers. This is what's called a multi-payer system. Many different entities are paying for our healthcare. It's very complex, it's very expensive, and it's very discouraging if you've ever tried to call an insurance company to find out how much something costs, then you begin to understand just how complex and complicated and frustrating these middlemen are in coming between us and what we want and need for optimum health.
I honestly don't know why it's doing this. It's the same problem. They're
It's
gonna
a
have to do the same thing again.
I'm so sorry.
Yeah, no problem.
Gosh, I hope this doesn't happen every slide. Oh my God.
Well, try the space bar because that,
Try this.
yeah.
Okay. Okay, am I there?
Yeah, we're good to go.
Okay, so our current system, as we've seen, is wasteful and ineffective. We spend 2 times what other industrialized democracies spend. And unfortunately, you'd think, oh, we're spending so much money, we must have great healthcare. We do have great healthcare. Unfortunately, a lot of us don't get to use it. Why? Because it's so expensive. So as a result, we have some 30 million people in this country that are uninsured completely. That means if they don't have any money, they don't go to a doctor. They go to an emergency room, and that costs even more from taxpayer expenditures. Or then we also have some 70 or 80 million people who are, here's that word, underinsured, just as my family was those many years ago. That means high premiums, huge deductible that you can never meet. And I figured out in those days, if our whole family got in a car wreck, say, and all needed medical attention, we would have to spend, to meet all of the 4 deductibles, we would have to spend some $48,000 in a year in order for the insurance to pay 1 penny. So that is pretty shocking. And those costs continue to go up. The Stanford Graduate School of Business has estimated that there is $265 billion lost every year, and that there is savings to be had with single payer of $223 billion a year over a 10-year period. So and that's from the National Healthcare Workers Union, that also estimated that we would be paying so substantially more in 10 years, 350 billion more. So it's just very ineffective. So many people are left out in the cold. And why is it, where is all this money going? We're spending twice what other countries do. About 30 cents on the dollar goes for profit and shareholder payouts. This is what a corporation is all about. They're about business. The more that they don't pay for you, the more they make for themselves. That's the bottom line, not our personal health needs. They also have to pay for CEO salaries, their retirements, huge bonuses. And boy, I'm telling you, the money that comes into insurance companies, United Health made $15 billion in profit in 2020. That was at the height of the pandemic. The administrative overhead is crushing and very expensive. That includes advertising, lobbying, billing, lawyers to adjudicate conflicts. It goes on and on. Billing clerks. They even hire special people to figure out ways to deny care so that they can save money. And by saving money for themselves, they make more money. So this, and none of this money that's being wasted, that 30 cents on the dollar, none of it contributes to actual care. So that is such an unfortunate situation. It worked, yay. So this is just a kind of an example of how our system today, which is a mess that we're every one of us wrapped up in and caught up in. And it is in fact a mess. So here is another perspective of that mess. And I love the Bucky Fuller quote, "You never change things by fighting the existing reality. to change something, build a new model that makes the existing model obsolete. Well, one thing we don't have to worry about is making it obsolete, because brother, it is really obsolete. We have a fragmented, expensive, wasteful system, and it does not serve the public well. The attempts to fix it and patch it up and prop it up, for example, Medicare, which was a wonderful advancement, absolutely fantastic. If you're on Medicare, you probably remember the day that you got the notice from your doctor, you're welcome to Medicare Day. You need to make your appointment, come in. And you think, I really honestly didn't believe it was going to be that good. But wow, to suddenly be relieved of the burden and fear and anxiety of how to pay for healthcare was transformational. Same thing with Medicaid, that helps so many people that have low income. However, it still is not saving money for the country as a whole, and it's wreaking havoc with our economy because of the spiraling costs. And the ACA, perched on top, again, helps some people in some ways, but until we build a new model, this underlying crumbling infrastructure at base is going to be our downfall. So what can we build in its place? What we call single payer is simply a way of replacing the multi-payer system. Instead of having many agencies with conflicting payments, remember all of those middlemen. We were paying taxes and fees and premiums, and so, for many instances, for programs that we never even use. And so then you have to pay again for yourself to be covered in some other way. And so the paying never stops. With single payer, every dollar that is now paid for healthcare would go into a single pot, and a single agency, which would most likely and obviously be a governmental agency, would be not the would not run the healthcare, but would organize it. And so that it becomes streamlined, rational, transparent, and effective. It's also known as national health insurance, also known as Medicare for All. We always like to add to Medicare for All, improved Medicare for All, because even if you are on Medicare, I'm sure you know that it has several disadvantages, namely dentistry, vision, hearing, long-term care, many other things that are lacking that old people frankly really need. So a single payer would be a one agency that then the people pay into that agency, and that agency pays doctors, hospitals, and prescriptions, etc. So I like this slide because it was created by a Dr. William Zhao, who is pretty famous in the troops because he created the single payer system for Taiwan, which is a really classic single payer system. And he also created a single payer system for Vermont. Unfortunately, that was never actuated, but his estimates for California, which I've never seen anyone do exactly like this, shows the potential, huge potential savings a year. And again, we're talking about administrative overhead. It makes things much more streamlined and gets rid of those confusing tiers of coverage, like this plan for this and that plan for that. And that would save a great deal. And then you have collective negotiation. This is really important because, as you may know, and you probably have experienced, drug prices are out of control. And there are no controls built into the way drugs are marketed. It's absolutely essential that Medicare or an improved Medicare for All, a single payer system, would have the clout and the power to negotiate with pharmaceutical companies Like we are the buyer, we are the buyer, and we demand rates commensurate with the rest of the industrial democracies of the world. Why are we paying 100 times more sometimes? And that also goes for medical supplies and claim records becoming more uniform and medical records becoming uniform. How many times you've gone to the doctor and to fill out pages and pages every time you go to a new physician and a new specialty, filling out practically writing a novel. So he is estimating savings for California to be around $80 to $120 billion a year, which is very significant when you consider right now we're paying $400 billion a year, and we are not covering everyone. About a quarter of the population of California is either uninsured or underinsured. So now we have, again, you see in the middle of our single payer tube where the people are putting all their money into one pot to be the single payer. Now, of course, what everyone always asks, as soon as they hear how great this is, how in the hell are we going to pay for it? And the answer is actually pretty simple, even if it's non-specific. And the reason it's not completely specific is because we haven't set it up yet. And it's really hard to predict the future exactly. But the estimates that have been made are conclusive that a single payer system would save billions, and in fact, over 10 years, trillions of dollars. So why is that? We already pay for 70% of everything we need to activate a single payer system that would address the medical needs of everyone. We already have that. We don't have to start from scratch. We would need some more, 30% more, to complete that necessary pot. But the outstanding take-home message is whatever we do to get that 30%, it's going to cost us individual consumers or patients a lot more than we're spending now. And I really like Bernie Sanders' hypothetical family of four making about $60K a year under a single payer system, getting their medical coverage from their employer. And he is talking about this family that spends about $20,000 a year on medical care. That means for their insurance plan, for their premiums, meeting their deductible with their out-of-pocket costs, and then even once they meet their deductible, paying those hidden costs we were talking about before that can be overwhelming. So about $20,000 a year, which that seems like a lot, doesn't it? 20,000 in a 60K income, that's a third. Well, I can vouch for that because our family was exactly in that position many years ago before Medicare, and it is devastating. So here you are with a choice. Do you want to spend $5,000 in, say, an income tax? Or do you want to spend $20,000 as you now do with your medical coverage and bills? So if you're spending $5,000 in, say, let's say income tax. Now, let me just back up just a minute because it doesn't have to be income tax, but it seems like that may be the best way to go. Everybody hates the word tax. And I think maybe we could change that. But anyway, there's been many different methods proposed for paying for this extra 30%. I always liked Elizabeth Warren's surtax on Wall Street transactions. I think that would be very effective and it wouldn't really hurt anyone. Then other proposals have included things like payroll tax, sales tax, gross receipt tax, property tax. All of those have been proposed to cover that 30%. Unfortunately, all of those things are pretty regressive. That means they impact people that are less wealthy than the people that are more well-heeled. So the most progressive, the most fair would be an income tax. I'm suggesting that perhaps we should call it something different, like maybe income benefit single payer initiative. Maybe that's too many words, but anyway, people do hate the word tax. So what is the no-brainer take home of this? Do you want to pay a $5,000 extra income tax and never pay another hospital bill, doctor bill, prescription cost, ever? Instead, you are given a little card if you are born, say, in this country or in California, and we have that system. And the card gives you instant access to any doctor, hospital, clinic, and gives you your prescriptions. And I even have an example of what that might look like. So I'll just give you a second to check that out. All the providers, including copays, 0. Deductible 0, monthly premium 0. So there you have a single payer system that supports everyone in a very equitable way and saves tremendous amount of money almost immediately and even more over time, as the estimates have shown. So I'm going to stop sharing right now and turn this over to Corinne, who from a physician's perspective has a lot more to say to flesh out all the things that I've forgotten and can give you a lot more insight. And we're really looking forward to your questions because we can't remember to say everything. And your questions are where you really gain a lot of information. So on with Corinne. Are you muted? You're muted.
I am unmuting myself, and now I'm going to share my screen, which just didn't work.
You'd think we hadn't practiced, but we did practice a lot.
Trying to get into the actual slideshow. And I can't get the top up and out of the way.
Are you talking about the meeting controls, the floating meeting controls?
At the top, yes. Wait, let's see if yeah. I can't get them out of the way so I can start my slideshow. And thank you, except that, how do I get the view? Oh dear. Okay. All right, so thank you, Patty. You covered a lot of materials and I will be repeating some of this in a slightly different way to get the same message across. So I don't know how, this may date us. You may recognize this picture from the movie The Good, the Bad, and the Ugly, the spaghetti Western. And what I want to say is we spend a lot of time saying how bad things are, and they are. But there are some good things in our current system. One of them is that we have very high quality healthcare. And people come from all around the world if they have some rare, difficult diseases to get treated in the United States. We have excellent hospitals overall. We have very well-trained professionals. We have very good research done, advancing medicine in many directions. We have our pre-existing medical conditions covered, thank goodness, due to Obamacare. And we have the potential to create the best healthcare system in the world for everyone. So what's bad about our system? Well, we have thousands of insurance plans, as Patty referred. We have premiums and deductibles that keep rising. We have a very inefficient, complex administration system that forms the bulwark of our insurance system. Women's reproductive rights continue to erode. And overall, unless you're in Medicare, and even with Medicare, there's a lot of health insecurity. And if you lose your job, you lose your insurance. privatized health insurance networks do limit our access to physicians and hospitals. Now there's the ugly. The ugly is that health disparities continue to grow in our system. There are 34 million people still uninsured, 74 million who are underinsured. Despite all of that, the health insurance and pharmaceutical companies continue to make billions in profits, as Patty referred to, and medical costs are the leading cause of bankruptcy in the United States. This is a concept that is unheard of in any other developed country that has universal coverage. They don't even know what it means. We are the only country among the 50 developed countries that does not have universal coverage. Ours is based on employment, and that started in World War II because during World War II, there was a worker shortage because everybody was sent to fight Nazism and fascism. And so companies needed to persuade people to come and work for them, and they couldn't raise wages. That was a government policy, so they offered health insurance, and that has stuck until even now. If we look at our spending per capita for healthcare, you can see from this chart that we far outrank any other country. The next highest country is Switzerland, and yet all these countries provide universal coverage. We're paying so much more, and what do we get? Well, don't be too alarmed about this graph. This graph, this spider web over here, are all the countries that have universal coverage. And in 1970, and before 1975, 1980, you can see we were pretty much part of the pack. But beginning when all these countries started developing universal coverage programs, and there are different ways they've done it, you can see their life expectancy went up. Where does ours go? You can see our line right here. It's gone down. We're the most expensive, and yet our life expectancy is worse than any other country. This is another way of looking at it. Our life expectancy at this time is 78.6 years. Every other country, it's higher. What are we getting for our costs, for the money we put in? Well, we have worse infant mortality. We have more deaths in the first year of life per 1,000 births than any other developed country. And if you break down that statistic more carefully, you can see that people of color actually do even worse than the white non-Hispanic babies. Our maternal mortality is also something that we need to be ashamed of. It's small numbers. I'm not sure what just happened. Oh dear. Oh well. It's small numbers. Oh, somebody entered the waiting room. Okay, I'm not sure if that's.
Okay, I'll take care of it. Yeah, I'll take
thank you. But I still have that floating thing right now. Let me get rid of that. Okay. So in terms of mothers dying before birth, during birth, or just after birth, we have more than any other country. There's no excuse for this, absolutely no excuse for this in the richest country in the world. The numbers are small, but still it's something that we should not have in our country. And once again, if you break it down, it is the women of color who fare a lot worse and have more deaths, pregnancy, than white women. Is there somebody talking? Okay. So what happens? I haven't got to look at the participants, and many of you, I shouldn't make assumptions, but I am assuming, like myself, we have Medicare. What does Medicare do for us? Well, if you look at the life expectancy among people in the United States, men and women, up to the age of about 65, you can see we rank we rank about 15%. What happens at age 65? Look at that. Our longevity increases and we become almost at the top of the rankings of all countries. There is something about having the security of having insurance and access that actually changes the course of our health and allows us to live longer. What's driving the costs? Patty reviewed quite a few. We have a for-profit health insurance system that needs money for marketing, administration, CEO salaries that range between $20 and $100 million a year, for lobbying to convince politicians to continue the system as it is, and then for profit to pass on to their shareholders. They save money by having narrow referral panels, meaning we don't have as much choice to choose what doctor we want to go to, by narrowing what drugs they cover, and by actually denying payment for certain procedures. I think this slide actually reflects absolutely the worst part of our healthcare system. It's a remark by Goldman about how sustainable business model is when you cure patients. And if you read the bottom, which I will read out loud, the success of Gilead, which is the company that developed a hepatitis C medication that actually cures hepatitis. And for those of you who don't know what hepatitis C is, it's a virus that causes liver damage, cirrhosis, cancer, and often death. So it cures this. And it's quite, as I said, in this country, we have high quality healthcare and research. So this country has developed a medication to cure hepatitis C. But if you look at the success of the hepatitis C franchise, it has gradually exhausted the available pool of treatable patients. In the case of infectious diseases such as hepatitis C, curing existing patients also decreases the number of carriers able to transmit the virus to new patients. In other words, it shrinks the market. And that is the bottom line of our healthcare system now, as it's viewed as a commodity and not a right. When you look at costs, you can see that the cost of a bypass surgery is almost 10 times more than the next highest country. Everything is incredibly expensive because of the complexity of the system and the need to make a profit. Pregnancy, having a baby, the average cost is $5,000 in this country. That's expensive to have children. In other countries, it's free. It should be free. We need another new generation. We need a new generation that's healthy. We spend a lot on medications. The pharmaceuticals have a stranglehold on how much we pay, as most of you probably know. People go to other countries to pay for their insulin, for their asthma medications, for some of the antibiotics, because they're so outrageously expensive and costing much, much more than in other countries. It's the same pharmaceuticals, it's the same manufacturers, and yet we're paying so much more. And that's what boosts the pharmaceutical industry for their profits for the rest of the world. So in a way, we're paying for the rest of the world, and we don't need to. One of the biggest costs of healthcare is the administrative complexity. If you look at, this is one sample, Duke Medical Center in North Carolina, which is a very good hospital. It has 957 beds and 1,600 billing clerks. I called St. Joe's and Mad River Hospital years ago, and they had similar statistics, although on a much, much smaller scale. More recently, I called St. Joe's again to try to get statistics locally, and it was so confusing, I couldn't even get any numbers. This is what happens when you see the doctor and then the doctor sends a bill to insurance. It starts right here. And then it goes through this unbelievable maze of validations, authorizations, coding, back again to denials, back again to let's look at it again, and coding again and recoding. And each one of these little squares is its own little industry that needs to justify its existence. So once it goes, you can't find your way through this maze. I would not recommend going through a labyrinth of hedges. You'd get lost forever. But let's say it does eventually get to the bottom, and there is the bill that's paid. So that is such a waste of money. When you look at how many administrators versus how many physicians exist currently, this is a fun graph. The yellow line is how many physicians have graduated from medical school and now are available to treat patients. The green is the number of administrators that have grown since 1970. The number of physicians have grown by maybe 100%, maybe a little more. The number of administrators over 3,000%. We need all these administrators to figure out how to deal with making money and also how to navigate the incredible complexity of our system. If you, oh, here, I don't know, oh, you're admitting somebody else. Okay, so if you look at how much we're spending, it's hard to believe that in 2017, we actually, our US healthcare system spent more just on administration than the entire US military defense budget. That's hard to fathom. That's very hard to fathom. And it's not going to healthcare. It's not going to direct services. I'm going to get rid of this floating meeting control again. Okay. And that money, as we keep saying, Patty and I, it's going to administration, it's going to bureaucracy, it's not going to healthcare. And this slide shows you how much we're spending per person, per capita in the United States just on administration, $843, much more than any other country, and yet how much we're putting into direct long-term care, which is second lowest. Maybe in Australia, I don't know what happens in Australia, why they're spending a whole lot less, but we're spending we could use that money and spend it on direct healthcare. So here is this dire picture I'm presenting, and then we add another layer. Then came COVID-19. What happened with COVID-19? Well, all the problems existed before, but it came to the fore. It became much more clear about how difficult it is for Americans to access healthcare easily and not go bankrupt. And a lot of Americans lost their healthcare because they lost their jobs, because in this country, jobs and healthcare are intertwined. So about 14.6 million people and children lost their healthcare. If you look at what happened in other countries, people lost their jobs in other countries as well. I mean, the pandemic, the virus didn't care, it went around the world. Look at the zeros. Nobody lost their coverage because healthcare was uncoupled from employment. And then once again, if you look deeper, you can see that the number of cases, hospitalizations, and deaths was much higher for people of color. And that could be for many, many reasons. One of them being less access to healthcare, and another is that many of people of color had some of the lower paying essential jobs with less protection, and that many people who don't have as much money live in more crowded conditions. So that all contributes to a higher morbidity and mortality rate. So whatever happens to the nation in general, it tends to be worse for people of color, immigrant communities, and poor people. One interesting fact that I just found in a New York Times article that refers to a Kaiser Family Foundation study was that there's a lot of controversy about why people are not getting vaccinated, and a lot of facts and theories. But one of the things that the Kaiser Family Foundation found was a big contributor to why people aren't getting vaccinated is their lack of health insurance. What happens with this pandemic? People are suffering. People are losing their insurance. People are getting more and more insecure about their health. And yet this was very, very profitable to health insurance companies, as Patty mentioned. Some of the companies made much more in the first quarter of 2021 than they made before the pandemic. So how are we all coping? Well, there's GoFundMe. I don't know how many of you have gotten emails to ask for money. I've certainly donated to a number of medical GoFundMes. And I looked up the GoFundMe website, and in the past year, they've had 250,000 subscriptions to start GoFundMe. There's something wrong with this. We shouldn't have to have a GoFundMe to help people pay for necessary medical care. As you project into the future, if we keep the system the way it is, we will have more and more people uninsured. And once again, it is people of color, who are suffering the most, who have the least insurance. And let's look at why people are uninsured. And many of the reasons are the coverage is not affordable. They're not eligible for coverage. They fall in the cracks between being not poor enough for Medicaid or Medicaid is the same as Medi-Cal in California. We call it Medi-Cal, but in the rest of the country, it's called Medicaid. They don't want it or need it because it's so confusing and they just don't have the hours to spend trying to figure out which insurance program would best suit them and at the least amount of cost. That adds to the signing up is too difficult or confusing. I found it confusing and I'm a doctor. And they can't find a plan that meets their specific needs. If they have a certain condition, you go through the fine print and they find it just doesn't cover it, or they lost their jobs. Underinsurance is growing as well. And the definition of underinsurance is that it costs out-of-pocket expenses are greater than 10% of the income, or the deductibles are greater than 5% of the income. And it's growing. What happens when people are underinsured? They have to pay the difference. So some of them use up all their savings. Some of them get a lower credit card rating. Some of them take on credit card debt. Some of them have to make a choice between medicine or food or rent. Some of them delay their plans for career change, advancement, or education. Some of them have to take a mortgage out if they're lucky to own a home. And then there's a number that declare bankruptcy. There's a concept that's coming through the literature now of financial toxicity and how that affects people who are sick with serious or chronic diseases. There is so much stress in this country. There's so much insecurity and it's related to finances. And that in turn, we're just beginning to look at it, may affect our immune system's ability to fight disease. We're going to become, and we have already become, a very unhealthy nation. Martin Luther King said it the best: of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. We need healthcare. And remember, this whole talk between Patty and me is that we need healthcare. We don't need multiple insurance coverage. Insurance is not healthcare. And single payer gets rid of the worry about insurance so we can then seek the healthcare we need with the choice that we want. It's interesting because, as Patty mentioned, we are already paying 70% of the cost of healthcare in this country and in this state. We do it with our taxes, paying for Medicare and Medicaid. We do it through our property taxes that pays for health insurance for public employees. We do it because we lose some of our wages, and that then goes back into the pocket of paying for more premiums or more deductibles or more copays. It's a lose-lose situation for everyone except for health insurance, for-profit health insurance systems, pharmaceuticals, and another concept, pharmacy benefit managers. It's a lose-lose situation except for them, and for them it's very profitable. And that's just another chart that shows you that 70% of healthcare spending in California is actually paid by us already. So we only need that 30%, and Patty had some good ideas about how that could be covered. So Medicare means stop wasting our money. That's what it means. Medicare for All means stop wasting our money. And if you look at the overhead of the major health insurance companies, you can see that the overhead to pay for, we mentioned the lobbying and the marketing and the profits and the complexity of the system and paying the salaries is much higher than for Medicare. Look at the difference, 2.3% versus 13 to 18%. Medicare already has it down. So single payer Medicare for All makes economic sense. And that's been shown by multiple studies and multiple economists. This slide actually validates what these studies have shown, and I will break it down quickly for you. The red line is how much single payer would cost if it was implemented tomorrow. It would there will be increased costs because more people will be able to access healthcare. That is something people who are not for single payer worry about. We want people to use healthcare. So yes, there will be more people using it and it'll bring the costs down. But study after study, and these are all the studies, show the green line, which shows that the money that is saved by using single payer. And Patty and I have reviewed that already. So the blue line will show the actual net savings of healthcare in this country as validated by 22 studies, including ones done by very conservative think tanks. I think much to their horror, but they couldn't refute the facts. And this is another graph that shows how much we're paying now, 3.24 trillion, how much universal coverage will cost. But if anybody tells you it's going to cost more, you tell them, but we're going to save more money. And so in the end, we pay a lot less. So what have the market forces done for healthcare in the last 20 years besides treating healthcare as a commodity? This is the summation. We've increased the number of uninsured and underinsured. We've decreased the choice of provider. We've diverted healthcare resources to areas of profit rather than need. We've underfunded the less profitable endeavors. We've created unaffordable prescription drugs, increased the cost of technology, and we have a lot of frustrated patients and frustrated physicians, all with higher costs. Not a good deal. If you were looking for insurance or shopping for something, you probably wouldn't buy it if you had a choice. What does single payer do? It offers real tools to contain costs because of many reasons, being able to negotiate pharmaceuticals, decreasing in medical malpractice costs because people won't sue as much because they feel that they will be taken care of. And there will be an emphasis on preventative care, and preventative care is always cheaper than going to the emergency room or dealing with an emergency surgery. Plus, one other big thing about single payer is there's this concept of global budgeting of hospitals. Right now, hospitals charge fee for service for the care that they provide, and they try to charge as much as they can so that they can then cover not only the patient care, but then take the profits from it and apply it to their capital budgets, building a bigger hospital, getting a new MRI, getting the latest technology to treat patients in the best way they can, and lobbying and marketing, advertising. Now, some of these things are very good and necessary. What happens under a single payer system is that the hospitals will negotiate with a governing board that controls the money, the one pot of money, and request a global budget based on previous years, how much they have spent on actual care for patients. And then they can negotiate and request funds for capital budget, meaning based on what is actually needed in the community. Do we actually need another MRI when there's 5 in a small area? Do we need to have lobbying of politicians to validate the fact that they keep getting bigger and bigger? Do they need to advertise? They won't need to advertise. Their advertisement will be based on the quality of care that they provide. Single payer Medicare for All is like Medicare, what we have now, but better, because it'll cover all prescription drugs, eyeglasses, dentistry, hearing aids, and it'll be funded like the fire department. It is a social service. Nobody will be left out. So that includes you, me, all our friends, family, neighbors. We don't have to worry. There won't be any GoFundMes. You can choose your own doctor and hospitals which you feel are best for you. And Congress uses the same plan that we use. So when they're using the same plan that we use, if it's not working well, believe me, the politicians will make it work because they're going to be as affected as we are. Most doctors at this time do favor single payer. The support has increased sharply. I've been working on this since 1989. So I'm one of those physicians that's been working on it. And this is a good cartoon to explain what we have now. And this little boy explaining, look, it's so much simpler. We could have a much simpler system. For more information, you can get this if you are interested, and this has been recorded. I'm not going to list them right now, but there is a lot of information out there. A lot of these sources do talk about what's wrong, but they don't come up with a solution at all, except to make the system more complex. But it does give you a lot of information about what's going on. Physicians for a National Health Program has a good website because it does also talk about solutions. And so does Health Justice Monitor, which is a very short, one page, once a week publication that are digitalized, that talks about a up-to-date change or idea of what's going on in healthcare, and then their commentaries, very deep, thoughtful commentaries about what's going on. And then I'm now going to give it back to Patty.
So just, we're taking more time than I thought we were, but just to go over the legislation that we now have before us, which is very encouraging. In California, we have AB 1400, which Guaranteed Healthcare for All, which is a bill that is similar, but actually improves upon the last bill that was presented to the legislature. And our senator in District 2 is Mike McGuire. He is a co-sponsor, and he is wonderfully supportive and for it. Our assemblyman, however, Jim Wood, claims to be supportive of the idea of universal health care, but his method or his ideas about getting there do not include single payer. He does not seem to be a fan of it. And so let's see, in the national level, we have in the HR 1976, this is the Bernie Sanders, no, sorry, this is the Pramila Jayapal bill. She's from Washington, the Medicare For All Act of 2021, also very complete. And the companion bill to that is HR 3775, Rocana, California. This is a state-based universal healthcare act, which is really important because it streamlines the process of getting that 70% we were talking about, which is bound up in our Medicare and Medicaid and other federal payments that we make. We want to bring that back to California. And this is the bill that would really streamline and assist that to happen. And our representative in Congress is Jared Huffman. And so I strongly recommend that people write, email, call our representatives, and particularly Huffman and McGuire, and thank them for their support, and admonish our Assemblyman Jim Wood for not supporting these bills because they will be so beneficial to all of us. I saw someone ask a question about that, and we can get to that too. What can you do? Support resolutions for Humboldt cities and community service districts and Humboldt County. We've been working on this with our groups, and we have so far secured resolutions from the service districts of Willow Creek and Manila, supporting both these resolutions, the AB 1400 and HR 1976. And also the city councils have resolved to support also from Trinidad, Blue Lake, and Arcata. And our sites are next on Eureka. If you live in Eureka, call or email or contact the city council members and tell them that you would like to see them support such an idea. This is going to be ongoing soon, if not already, it's already in the works. And we're also have our sites on the Humboldt County Board of Supervisors. And they also need to hear from the people. That's what we're working toward. Envision a universal just healthcare system. Having it in your mind means it will come out of your mouth and you will talk about it. And talking about it is so absolutely important. That's why we're talking about it. We consider information to be power. Knowledge is power. And we want to empower you to help us all have this wonderful, beneficial change to our healthcare system. You can contact us at healthcareforallhumboldt@gmail.com. And if you would be interested in becoming a member of our chapter, our chapters, which include the two different groups, you can join either one or both of them and you would be in our group because we're a small enough area that we have the two groups together working for the same goal. And we would welcome you to our meetings, which are every fourth Wednesday of the month from 5 to 6. And we do Zooms. We've been doing Zooms for almost 2 years and it works out pretty well. And we're a very dedicated, committed group, and we have lots of activities going on, and we just keep working away on it one step at a time. And we know we're going to get there because we're closer than we have ever been before. So many more people know about single payer than used to. So is that the end of that, Corinne?
Yes.
Okay, so we want to move on to questions. And
Okay. And
I
we-
just lost my, I think I just am out.
no, you're here.
I am?
Yeah,
Oh,
you're with us.
good. I don't see myself.
I see your desktop though.
Okay.
I'm gonna stop sharing your screen.
Okay.
There
You
you
don't
go.
see anything personal
Okay,
here,
here we
any
are.
emails. We have a few questions in the chat. The first one is from Susan, and she asks, how will equitable access be achieved in rural areas?
Should I answer that?
Go ahead, Corinne.
Okay, equitable access, because everyone has equitable access, everyone will have that same insurance card. It will save rural hospitals, and it will allow doctors to practice in areas that are most needed. Why is that? Because right now hospitals are more concerned about growing and getting and consolidating and providing some services that we don't even need. And poor rural hospitals can't survive because they can't make ends meet because they're small and because people in rural areas tend to have Medicaid or Medi-Cal versus private insurance. When we get rid of all the different kinds of insurance, then rural hospitals will have a better chance of thriving because they can negotiate with this governing board and say, look, we have this population, these are the needs, this is the money we need. And if we need to get bigger, they can negotiate a capital budget as well. For physicians, it'll be easier for physicians to practice in rural areas because right now, when physicians have to pay, there are some people who've graduated that I know of that have debts of $500,000 from their education in medical school and residency. They can't make ends meet, so they don't go into primary care, which doesn't pay as much, and they stay in cities where there's a lot more, they can go to specialties and they can practice more easily. When you have a single payer system, it'll be much more, it will be easier and more lucrative to go to an area where you're needed and you can treat based on need and not on money. So rural areas will benefit from a single payer system.
Kind of going along with that, Patricia Stammer asked, what is the biggest holdup to single payer?
Oh, the biggest holdup to single payer is the opposition from the corporate for-profit entities that are becoming so wealthy, and as Corinne noted, the conglomeration of hospitals and clinics into huge monumental entities that are more interested in making surplus, which they call profit, or the profit, which they call surplus, than in taking care of not just their patients, but also their employees. Nurses suffer terribly in these giant hospitals that have so much money. Things like this definitely get in the way of our receiving adequate health care.
You know, remember that insurance companies are there to make money, not to pay for services. That's in every branch. And so we need social insurance that can actually pay for services and not try to keep the money.
And the other thing that gets in the way is the lack of political will. There's nothing that strengthens political will more than money. And we have huge, enormous, wealthy agencies that are giving our legislators so much money that really turns them into blockers of change and helps them to keep the status quo going for those giant corporate interests.
You know, it's interesting when we asked to speak about Medicare for All, we realized a lot of people didn't know what it is and what it can be. And so the lack of information, we don't have the tools to convince people to buy drugs they don't need, because we don't have all this money for marketing. All we have is word of mouth. We have one-on-one. So we're hoping that after a presentation like this, you are interested in continuing to learn about this situation and the ability to set up a single payer system in this country. It really is word of mouth and public pressure to deal with the corporate structure of our country right now.
Yes, political public pressure is absolutely key. It's absolutely essential. As somebody said, the only thing to counteract organized money is organized people. And so we work hard to organize people and organize the pressure campaigns for our legislators to counteract the kind of pressure that money brings to bear.
Patricia, you had a question?
How are you going to convince people who are younger than we are? I mean, I can't imagine this will be enacted in my lifetime. I'm 70. How old am I, Patty? 77, 78, somewhere in there.
Yes.
I don't know, I forget. So I just don't, it just seems like such an uphill battle but you know, this country is founded on that, uphill battles of stupid shit, excuse me. But I just feel like if we don't engage people who are younger than we are, who right now they just think they're going to live forever, I just can't figure out how this is going to make any progress. It's like banging your heads against the wall over and over and over. And, you know, well, we'll wait until, you know, the congressman we don't like is, you know, it's just an endless loop of stupid. And
It is, you know, it is a challenge. And it's one of the things we're always talking about. How do we get younger people into the movement? But believe me, there are a number of younger people who are. There's a group called M4 All, Medicare for Medicare for All. And they're starting they had a demonstration at the end of July. They're going to have another one October 30th, where they're going to have a Day of the Dead, and they're going to have a sit-in in San Francisco to show how many people have died as a result of our healthcare system. PNHP had a meeting with some of them. They were all young people. They were all people of color. So I don't know what gets people invested in it. Some of it has to do with relatives of theirs dying. Some of it has to do with some of them getting sick. I worked at HSU, and often I had to explain to students, no, you have an insurance that doesn't cover this area. You're going to have to get down to Santa Rosa, or you're going to have to go to San Francisco to get your care, because I cannot get authorization. After 2 days of arguing with the person who had to tell me no, I could not get through. And so then they begin to understand. But some of them just do have a more awareness of community. They understand that what hurts one person hurts all, that when one person is healthy, that will help many other people become healthy. But it is a challenge all the time. You're absolutely right. How do we mobilize younger people?
And don't forget that Corinne, PNHP has its
Snap
student doctor
chapters.
program, and
Yeah.
it's just really encouraging young people in medical training that have banded together as an adjunct to PNHP. And that is really important, because the AMA has changed a lot over the past 50 years. It started out to be adamantly against any kind of universal health care, but now they're so screwed over by insurance companies that they're going, wait a minute, this isn't working. I think we really need to go for this single payer.
That's true. And the AMA is not PNHP, but AMA has a medical student section, and they tend to definitely take positions that are much more progressive. And PNHP has a medical student chapters in different medical schools. And believe me, they are strong. Some of them, not all of them, but some of them are really strong.
seems like you need to find a way to convince them with some other method besides endless statistics, because obviously those prove your case, but getting people to listen to that is, you know, almost impossible. And not just in this field. I mean, we are overwhelmed by statistics and stupid. This is the second pandemic. It's the pandemic of stupid. So how do you get past that and convince them with something that touches them besides that glazing look they get when you talk.
We get more and more public support every year, as Patty said. When they lose their job, they all of a sudden realize they're vulnerable. When they can't pay their bills, people realize they're vulnerable. This is all ages. Actually, we're lucky in Medicare. We don't have to deal with that most of the time. But, you know, when people are hurting, then all of a sudden they start seeing that there's another, that we need another system. And when we talk about it, we can say there are other systems. We don't have to live the way we're living. Canada has a single payer system right across the border. And, you know, there's lots of myths about that and some concerns, and we can talk about that at some other time. But overall, actually, American physicians are moving to Canada these days to practice there because they just can practice medicine when we're trained. I see some other, Alex, did you want to go over some other questions?
Yeah. Jane actually asks, what will it take this happen in reality?
It's definitely going to take political will. I love there's a famous quote by that great orator, Everett Dirksen, who said, "When I feel the heat, I see the light." And that's what we have to do, is bring heat to these legislators who are ambivalent, are swayed by the financial contributions. And I think massive public demand, just like, I mean, there's such a, you know, the tipping point, just like the Berlin falling or smoking becoming almost obsolete. It can happen really fast when you reach that tipping point, but it takes public education and public demand. And it takes people in the streets, people at the Capitol, people with banners and signs and letters and emails and op-eds and letters to the editor, and constantly talking to everyone you know about it. This is the way that messages spread.
It is a bipartisan issue, believe it or not. Catherine, looks like your hand is up. You're muted, Catherine.
You're muted, Kathy.
Sorry. I'd also like to add, if anyone is a part of an organization, be it whatever, a Cooperation Humboldt, a local organization here in Humboldt County, or wherever you live, if you're not from Humboldt County, a Democratic Central Committee, wherever, the organizations that you belong to, take this to your organization and talk to them about it and get them to sign on to, there's a letter out right now, encourage them to talk to their city councils about the resolutions that we're working on. Be involved, you know, you don't have to be totally your whole life involved, but any organization you belong to, bring this to them and share your knowledge and make a conversation. The more of us that have this conversation and understand what's happening, the sooner this will happen for us. And
There's
thank you, Patty.
There's a concept that's developing called relational organizing. And as Catherine said, go to your groups, go to the groups you're involved with, but start with a friend. Start with your family. Family sometimes harder, but start with a friend. Just say, do you know anything about single payer? You know, I just went to this talk and either I liked it or I didn't, but I learned something. And what do you know about it? And, you know, just start there if you're not ready to deal with the masses.
No, bring one person along with you.
Okay, I'm sorry. I had a second question, which is what specifically is needed to change Jim Wood's mind? Because that's where our legislative block is from our district.
I see Patty chomping on the bit.
We are working hard on changing Jim Wood's mind. We've sent him petitions and letters, and we've gone to his office and we've demonstrated outside his office, and we've had him on Zoom meetings. We had one just a week or so ago, and he adamantly maintains that insurance companies should have a role in changing this system to universal. And he's like Germany. Well, Germany does have insurance companies, but they are strictly and carefully controlled by the government. They are not for profit. And what they can do is carefully overseen. And I said to him, do you actually think the likes of Cigna and Aetna and United Health would succumb and kowtow to a governmental control over them. And he actually laughed because he knew how absurd that sounded.
And also Germany is looking at a single payer system because so many people are unhappy, including physicians. But there is a petition, and Catherine referred to that. And if you're interested in signing, everybody can sign it individually. And if you're with a group, you can sign it as an organization. And I'm not quite sure how we can, if you go to, right now, if you go to CNA, which is California Nurses Association, they have a website and they have the petition on their website. Isn't that right, Catherine? You're muted. Kara has one. Kara has one.
It would be Kara that would have it. It's the California Alliance for Retired Americans, and I will put in the chat their address. It's just californiaalliance.org. I'll put that in the chat, and you can look there. For the California Alliance for Retired Americans, this is the big #1 issue they're always working on. I'll put that in the chat.
Yeah, and we're getting a petition to Wood. So he knows people in his assembly, because we have the power, we're in his assembly district, say we want single payer.
Thank you.
Lori looks like she has a question.
Oh, great. You know, if it were possible, you know, to become just like a single payer state, you know, like California. I mean, to me, that would be hopeful, but I mean, it couldn't work that way. We'd have to do it as a country, right? And as a country, it seems that, I mean, all the states would have to be on board. And it's just the idea that, my God, like Congress, our country, I've never seen it so divided about even the most simple, basic things. And, you know, it doesn't give me a lot of hope.
Well, you know, it's an ongoing discussion, state versus national, national versus state. Which one should go first? Which one? So what we've done over time is say, let's go parallel and work on both and see which one can go ahead. California is the 5th largest economy in the world. It can afford to have single payer. And I know Patty was going to say in Canada, it started province by province. Saskatchewan started implementing single payer. It was the only province that did it. And then the other provinces saw and went, whoa, you're saving money, you're providing better care, and they immediately implemented it as well. So it's whatever works. And so we can work on both, we can work on one or the other. There's plenty of us to deal with things going around. And don't get too discouraged. Getting discouraged can make us passive and cynical, and that is exactly where the people in power would like us to be, because then we aren't politically motivated to move and to make things better, whether it's the environment, social justice, health justice, it doesn't matter. Fight that cynicism, fight the depression. If you get it, just recognize it's part of maintaining the status quo, and it's important to try to fight it.
Yeah, thank you.
We have a question in the chat, and it goes, Medicare often pays extremely low reimbursement to healthcare providers, less than it costs them to provide the service according to many. So some don't accept Medicare. Would that be a problem with a single payer system?
No.
It can't be a problem because everybody would be paying the same. There won't be tiers. Right now we have tiers and layers of payment. If you go to the hospital, you may, and say you have an appendectomy or you have a colonoscopy, there may be 4 other people, 10 other people in that hospital having the exact same procedure, and they all pay a different price. How crazy is that? Depending on what kind of insurance they have, and a lot of other conditions. And it makes no sense. Everyone in the single payer system, everyone pays the same, everyone is paid. All procedures are paid the same, all prescriptions are paid the same, and all providers are reimbursed the same for everything that they do.
Let me talk about from a physician's perspective, because I deal with this a lot. Physicians, you're right, physicians find that Medicare doesn't pay enough. And so when you say Medicare for all, some of them really get turned off. If you point out that if you get rid of all the administrative work that Patty referred to, the 30% out of every dollar that a doctor earns, that is 30 cents more per dollar that they're making. It also frees them up from administrative work to actually see patients. And organizations like the AMA or the state organizations like the California Medical Association can negotiate with the governing boards that manage the trust funds, and they can actually say, well, we're not making enough money. We need to negotiate a slightly higher rate. And that's the beauty of it. It can be negotiated. So even though physicians are very wary of Medicare rates, they actually would do a lot better with single payer and be able to practice medicine the way they were trained.
Margaret, I saw that you had your hand up. Do you still want to go ahead and ask a question?
My question was answered.
It looks like we covered all the questions in the chat.
I see, somebody raised their hand. Theodore? Ted?
I wonder
Sorry.
if there's anybody who has an opinion or a fact about the quality of education of doctors in countries that have single payer systems, where the doctors don't get as much money.
In Canada, they make as much money as we do, and people, there's a quote I saw, it goes to the effect that whatever we do, somebody's going to complain about it, no matter what, there'll be something wrong with it. But overall, you ask most Canadian physicians, 20 years ago, that some of them were moving to the United States because they saw they could make a lot more money. But now they don't want to move. They're happy practicing medicine the way that they can because they don't have to deal with all the administrative costs. Now, Taiwan, people are very happy. As in somebody in Japan that doesn't have single payer but has universal coverage, healthcare, as somebody said from Japan, it's like the air we breathe. It's part of the air we breathe. So people overall with universal coverage are pretty happy with the care that they get.
Yeah, but they have it, so they don't have anything to compare to.
Well, they can compare to other countries. They can look at their statistics. If you recall, the statistics I showed in the first set of slides that I showed show that morbidity and mortality are much better in all these other countries.
Mm-hmm.
Maternal mortality is better. All of those statistics show that they provide better care.
Another thing is people in other countries, they know what's going on in this country and they are horrified. They are disbelieving. They can't believe there's medical debt. There are people dying. There are people losing their homes. They're going bankrupt. This does not happen in their countries. And all the complaints that they have about their own system, someone falls through the cracks or something doesn't work out quite so well. And they say, well, would you rather have a system like the United States? They go, oh God, no, anything but that.
Yeah, I was just talking about the doctors' salaries.
Yeah.
My daughter lives in Vancouver, and she has gone through a long series of things with her eyes, doctor after doctor, and so on. So her experience is, I'm talking for her now, so I should really ask her what she would say, but.
Well, as I said, they'll always, there will be individual. We have that here. We have that in France. We have that in England. You will find people who get caught in a system that doesn't meet the needs, the individual needs. And yes, there's probably her concerns are very, very legitimate and her frustration is very legitimate. And we have the same thing in this country. We can't go by, we can, and that's the way to improve the system, is to take these individual stories and deal with what is in the system that is preventing your friend from getting the care she needs. In Canada, they can look at it from a systemic level and say, okay, well, maybe she's not the only one. What's going on that people are not getting their ophthalmologic care? What are there long waiting lines? Are there not enough ophthalmologists? What's going on in Vancouver? What's going on in Alberta? And compare. We don't have that ability at this point.
Uh-huh.
So there are some, yes, I'm totally validating your friend's experience, but how can we make it better? And it's easier to make it better under a single payer system, I think.
Okay.
Does anybody have any questions? I know we're a little over, but I want to make sure everyone gets their questions answered.
If not, I want to, oh, Wheaton? Unmute yourself.
Thanks, Jane. I just have a question. I watch the terrible hyperpolarization and the way the Republicans are very effective at making anything that's good for human beings sound awful, and they love to use the word socialism. So they talk about socialized medicine, and half the room wants to run away like there's a smell bomb going off in there. So how do you get through this socialized and the other things that they immediately throw out to scare people away? How do we get through that?
Well, I think it's pretty evident if you remind people that we have many social, quote unquote, programs in this country, starting with simple things like the library, and then the fire department, the police department, and the roads and road construction, and on and on and on. So many social programs. This is just another way of addressing a social need, a common good. It's not turning to socialism. It's addressing common good. And I think that when people understand that, it's not hard to accommodate the idea.
The other thing is, it is not a socialist model. The NHS in England is, in a way, in that England owns the hospitals and the doctors actually work for the government. We do have a socialized system in this country, the VA, and I did notice somebody say that only some people can get full service in the VA. Well, that could be improved. But if you do get full service, you get really good service and you don't have to worry about bills. But that's only one aspect of our system. We have an English model, we have a Medicare, which is a single payer model, and then we have the Wild West, which is like everything else, totally messed up. And, when people say socialism, it's just a trigger word. It is a trigger word, as you know. I know you're saying, you know that. But what we have to emphasize, this is, as Patty said, a social insurance system, but it actually allows private delivery of care to flourish. We are losing individual small physician practices in this country. They cannot afford to deal with the rules and regulations and the fraud and the expense of running a practice. Under single payer, those small cottage industry physician practices could flourish because it would be so much simpler. I've always chosen to be salaried because I didn't want to deal with the business. I never went to business school. I went to medical school. But, sometimes I think, oh, wouldn't it have been nice to have my own practice? But not under the system we have now.
Thank you.
Well, Lori, do you still have a question? Your hand is still raised.
Thank you. Yeah, just one more real quick. Thank you. The penalty that that folks don't have insurance, the penalty they get on their income tax. Just two things. I'm wondering, that the penalty money, what do they do with those funds, the penalty? But also, the thing is, people are justifiably angry, about that when they have get a penalty, because they don't have, medical insurance. And they'll, write it off saying, well, that's socialism for you. And it's just one more thing of, probably, misinformation. But I was just wondering, what do they do with those funds that they get?
I haven't heard about a penalty. Have you, Patty? You're muted. You're muted. Patty, you're muted.
The penalty got eliminated.
You're talking about the ACA, Obamacare.
The individual mandate, that got eliminated. That doesn't exist.
Taken away. That was taken away.
I'm totally sorry because I just didn't, I'm sorry. I wasn't aware. Thank you very much. Yeah, thank you.
But, under single payer, everyone would be in, nobody out. So there's no penalties. You're in. It's paid through mostly taxes, and we all pay taxes.
All right, yeah, thank you.
I want to thank our two speakers, Corinne and Patty, very much for your great presentations, and you deserve to be congratulated for the work you're doing. And I hope we can get a lot of people backing this and a strategy to make it happen. I know you all have them. And the more publication we can get of that, and the more community we can get behind it, maybe we can change a few minds and
We
make it
hope so.
happen. That'd
We
be
want you
great.
all
And
to
I
join
want
us.
yeah, and I want to say that next Monday on October 25th, we're going to be talking about social justice philanthropy, giving to make systemic change, with Anne Brock Katz from the Humboldt Social Justice Donors Circle. So that's something in common with our discussion today as well, because this is a social justice issue. So thank you all for coming. Thanks to our presenters, and we look forward to seeing you again next week.
Thank you for having us.
Thank you.
Thank you.
Our pleasure.
Thanks so much. Learned a
Thank
lot.
you.
Oh, and if any of you want us to speak at any groups that you're part of, we're happy to do that. Aren't we, Patty?
We are so happy to do that.
Thank you,
Just let us know, healthcareforallhumboldt@gmail.com.
Thank you so
It's
much.
also, Catherine has spoken publicly as well, Catherine Donahue, so she's another source we have.
All right.
All
Take
right.
care, everybody.
Bye, everybody. Thank you.
I